Hello and welcome on the occasion of this afternoon session dedicated to monitoring and follow-up following this launch, which has been, pretty short-lived for some of you. Mia Ada is with me. Mia Ada, I'm in charge of the regional unit at Santé Publique France, and Jean-Philippe Amat work at the ANSAT in Lyon. And we have the heavy burden or the heavy task of facilitating this session. I'm hoping that you will be enjoying the program for this afternoon session. Thank you very much for offering this duet with this double act with me. Now, this session will be twofold. We'll have 4 speakers in each. Overall, we'll have time for Q&A. 5 minutes after every one of those presentations, and we'll have a 15-minute break, and we'll come back for a 45 minutes roundtable. This will be in French and English languages with simultaneous interpretation services on hand. We'll dedicate this afternoon to the topic of monitoring. You have a variety of constraints, a variety of innovations as well. So this afternoon we'll focus on technological innovations applied to 4 different fields. And then we'll be able to talk about what these innovations offer, what can be criteria for innovations in terms of monitoring can be transposed, can be useful, can be applied on the basis of what's happening and on the ground, and how can we capture information to be in capacity to take action to mitigate risk for human-animal populations. Let's start without further ado with Annabelle Lapostole. She is an epidemiologist at Santé Publique France in the regional unit of Mayotte. So thank you very much for coming all the way from Mayotte. You are expert in hydric diseases. Cholera has been keeping you busy lately, but you're here to talk about an application, a monitoring system, a community-based monitoring system in the context of hydric crisis in Mayotte. Thank you very much for your attendance here. So we've developed this monitoring system, and we can be reporting on the reality on the ground as opposed to kind of more conceptual technologies. I'm going to be talking to you about a community-based monitoring system in the context of water crisis in Mayotte from 22-23. For those who are not familiar with Mayotte, Mayotte is the youngest French département. It's been a département since 2001. It's a very young département. An overseas département in the Indian Ocean between the African coast and Madagascar. Population of 320,000, 50% under 15 years of age. National Statistics Institute estimates that 40% of the population is non-French national. 70% of the population lives under the poverty threshold or the poverty line on the island of Mayotte. And this department has the lowest medical density with 48 physicians, medical doctors for 100,000 inhabitants. Survey in 2009 demonstrated that 50% of the population renounced care, healthcare services. In Mayotte, there are many informal neighborhoods. 40% of houses are in corrugated metals. You have the townships in a picture of the townships and settlements in Mayotte. And 35% of dwellings don't have any running water. and in some areas this proportion is much higher. And 10% of housing or dwellings don't have electricity. In Mayotte, 75% of the drinking water production comes from surface waters. As to here's retention basins. These are huge water reservoirs on the surface, so overground, and riverways. Water and limited desalination or desalination units. There are 2 seasons in Mayotte, the leisure seasons and the rain seasons. And in 2022 and 2023, the rain season has been very limited, has been very dried, and the water levels in riverways and has made it impossible for the whole population to be supplied with water. You have the quantity of water on the tap, the pressure of water when it reaches the tap. So, over the weeks, and restrictions were introduced, first of all, with a night, once a nighttime switching off of the water supply, and twice a week, and up until December 2023 with 10 hours of access to water with 50 hours of no water supply. There's been lighting up of these restrictions related to water supply, but we have 24 hours periods where water is off, and followed by shorter periods where water is available on tap. So this is a challenging situation from that water standpoint, which can lead to think that we are experiencing hygiene issues, sanitation problems related to hydric diseases. It'll be for informal dwellings, and there are very many of those in some areas. So community-based monitoring, what is this about according to WHO? This is about the detection and systematic declaration by the community of significant event for health occurring within these said community. So this is monitoring on the ground and from the people belonging to the population and within the population to be monitored. And this is part of the standard monitoring approach in Mayotte, as in other offices, French overseas territories. And monitoring is often based on resorting to healthcare services, on E&E services, on freelance medical doctors. But in Mayotte, a significant part of the population could not be captured by this usual approach to monitoring. But this is about involving the, thanks to community-based monitoring, a much wider part of the population, and this allows for data to flow in, and it is used when there's poor performance of monitoring systems and non-existent, or when they are very far and few between, or whether they're focusing on populations that are difficult to reach. So this community-based monitoring system has been put in place in Mayotte, was introduced in Mayotte with 2 main objectives, from which interventions were considered. Objective number 1, aimed at alert and alerting. We wanted to monitor acute gastroenteritis evolutions in these informal dwellings, detecting cases of dehydration for the under 15. And the intervention as planned in this, within the framework of this objective number 1, was to get consulted with emergency services, frontliners on this, and emergency services knew that, frontliners knew that emergency calls could come from this emergency. And in case of severe dehydration in children, data would be monitored, and then serving of oral dehydration supplies, so as for dehydrated citizens or members of the population to be rehydrated. And then management impacts. And we wanted to monitor evolutions of access to waters and sanitary situations when it comes to access to hydric resources, as well as looking at impoverished neighborhoods in terms of and access to water. In terms of targeted population, you can see on the map, there's this map comes from the INSEE, the National French Statistical Institute, dating back to 2017, and neighborhood in orange, darker orange, are the most disadvantaged neighborhoods. They're located in Mamoudzou municipality in the east. So the main municipality with a strong population, and Makou, a northernmost community. Targeted area for this community-based monitoring approach were defined as priority by the regional health authority in terms of access to water, challenged. And these are neighborhoods for which we are aware of the fact that waters do not reach the dwelling, and for which there could be provisions put in place, such as water fountains, and they work with prepaid cards, and people can, and the population can get defined quantities of water or ramps, which are just taps provided for the whole population for free, for people to get their supplies of drinking water. And these fountains and ramps were either far or failing for technical areas in those neighborhoods. In total, we're talking 40 neighborhoods that were identified. And a source population were at the under 15, and in particular the under 5, and for whom we know that severity of acute gastroenteritis is the highest in epidemic periods, and presentation to emergency services. We're talking 85% of those for acute gastroenteritis cases. So data. And run until the end of April, and the neighborhoods targeted this as part of this community-based monitoring approach. Well, we started monitoring in November 2023, and between November 2023 and end of April 24, we covered 12 out of 17 municipalities, 29 villages, 64 neighborhoods overall. That's in small captions. But every neighborhood, bear in mind that every neighborhood could be visited once or several times, is for the associations that are involved on the ground that cover this community-based monitoring when they are doing their visits in these neighborhoods. As no monitoring systems, community-based monitoring was subjected to a protocol, and exchange of information or fell under a protocol within the Hospital Center of Mayotte, the regional health authorities, the associations, and Santé Publique France. So on the ground, what's happening? It's associations and visits neighborhoods. They go around neighborhoods, and associations choose when they want to visit, and then mediators collect data. So these mediators come from the population, local population, and data are collected on the basis of paper-based surveys or questionnaires, and then they are input online using an application that's available via smartphones. The first two questions are questions about the targeted objectives for the purpose of alerting authorities, and we're looking at detecting a child who does no longer eat, who hasn't drunk or hasn't had food for or hasn't eaten food for 2 days. And so associations, mediators have an alert sheet designed by the regional health authorities indicating what conduct they should adopt when such cases are identified. Second part of the questionnaire aims at answering the assessment objective, and questions focus on the dwelling, the households as to the type of consumption of water and the type of what consumptions, and in terms of the washing of raw vegetables. So there's a question about this. And then households are asked whether they boil water before cleaning food. And this question is as per recommendations in case of water shortage after water is off. So it is recommended to boil water before consuming it. So the so-called reflex sheets designed by the regional health authorities, first and foremost, a tool for mediators to remind them of the, as a reminder of the prevention messages and what conduct should be adopted when a dehydration in a child is detected. And you can see these reflex sheets on the right-hand side, and there's the in-house recipe for oral rehydration in case no sachet is available for associations or when they're not around, providing information to the families. So these are simple recipes: one coffee spoon of salt, and then a rehydration sachet. Since the introduction of these between November 23 and April 24, about in excess of 2,000 dwellings have been surveyed. Really high level of acceptance, and 2% of households have refused to take part. And there's been people calling the toll-free number, emergency number, and we've seen the extremely variable percentages of episodes of gastroenteritis in children. This could go all the way up to 50% in some neighborhoods. So this is but one example for one neighborhood, which is located in Kawini village, the Tulupuni neighborhood. This example has been selected because it is an interesting one in terms of our objectives to assess and the magnitude of hydric issues. There's been one visit in week 6 and week 1 as part of the water crisis. From week 47, the entire population was distributed bottled water. So there's a baseline before this water distribution and one after. It is distribution of bottled water. What we can see is on the bottled water, these are the blue bars right underneath the red bars. And we can see that between week 46 and week 47, the proportion of households drinking bottled water has doubled. However, what we can also see is that we've gone from 58%. It means that 42% of the population in this neighborhood did not drink bottled water despite the availability of such bottled water for free. And another interesting aspect is this recommendation to boil water. I'd like to tell you right afterwards why we have a counterproductive result there, because the dark red bar is the result in week 1. About 42% of the population that boils water, and in week 46, before the visits and before the prevention measures were explained in the local neighborhood, but more people who would boil water before consuming it, around 48%. So at the end of the day, despite the fact that we shifted from and we run preventions and recommendations, we had fewer dwellings that would, or households that would boil water. And then riverways water, the third blue bars from the top. And we can see that 100% of the population, we had, riverway water was used for drinking purposes, although in week 47 it was only 45%. So that can be explained very simply. In week 47, week 46, in dry season, so we have limited flow in riverways, and then week 8 with rain coming down and riverway flows, which flow was much stronger. The limitations of the surveillance system, community-based monitoring system approach, is that potentially there's a selective bias. And when we come to the neighborhoods to survey people on GA and prevention measures, people with sick children will tend to approach mediators to show their sick children. So we are probably underestimating the phenomenon. And there's probably a declaration bias. As well as a legal population there, and hence on stepping out of their neighborhoods and having people from outside coming into the neighborhoods might trigger a stigmatization going on overall. So and in terms of the acceptance of community-based monitoring, a collective of citizens, and that have been set up in Mayotte, and you have a few articles. Associations have been targeted and by these collective of citizens, these groups of citizens, simply because associations come to the help of illegal immigrants, so undocumented migrants. These the conditions as recommendations are not necessarily applicable. This is what we see. And the recommendation is not to use this water from the riverways, but it's often much closer than the ramps and the fountain water supplies. So people will always go to the nearest places of where available, where water is located. Some of the cases, there's a need for healthcare professionals. Mediators have been trained for so hydric risk and cholera and gastroenteritis risks. And other people amongst the populations can approach the frontline services for cases of other sort of ailments, rushes, amongst others. So there hasn't been any measures of intervention for water supply in some of the areas where it has been shown that there was a high prevalence of gastroenteritis. And the risk is for the answer to be the opposite of what was expected. If there's a prevalence of gastroenteritis in some of the neighborhoods, a political response is to dismantle these and to pull down these neighborhoods as opposed to addressing the issue. By way of a conclusion, can be said that we've reached the objective of community-based monitoring. There's a visibility in this disadvantaged neighborhood of what's happening, and any cases of dehydration, we can follow issues with regard to access to water. But unfortunately, this has not always been followed by the actions or intervention expected by associations and the populations. And the risk might be for associations to lose their drive when they see that the communication is not followed by concrete actions. And again, this is also about the project for the future might be about prioritizing these community-based monitoring to the most vulnerable parts of the populations beyond acute gastroenteritis, can be viruses or natural disasters. And currently, we are adapting to allow this community-based monitoring to alert on possible cases of cholera. And a big thank you to all of our partners, and in particular to the Prevention Department of Regional Health Authorities, with which we've been working very closely on AMATSA, and obviously all the associations that have been super supportive, and the Hospital Center of Mayotte. Thank you very much for your attention.
Merci beaucoup, Annabelle.
Thank you, Annabelle, for this presentation and this immersion. As a reminder for those of you online, you can submit your questions. A bit of time on our hands for a couple of questions in the room.
Oui. Si vous pouvez.
If you could introduce yourself before anything. Jean Godarix, I'm from the Marseille University and I'm working here at Santé Publique France. I would like to thank you, first of all, for the presentation of your works as the ongoing initiatives. Did you manage to compare those results, even though it might be early, to other community-based surveillance systems, such as the one put in place by the Red Cross in Senegal or in other countries? No. At the moment, we really tried to focus on the implementation of those initiatives, and we are still at the tasting phase. We didn't manage to compare our systems, but we didn't reinvent the wheel. We will be able to compare what we've done with what was done, because we got inspired by existing systems. Thank you. Do you have another question in the room? Martine Ledrans, Santé Publique France. So first of all, I would like to congratulate you for this presentation, especially because you have to work in difficult conditions. When it comes to classic surveillance, did you manage to find specific perks, specific advantages in your system, which is an early detection system? Did you manage to detect households or clusters that you didn't manage to notice with a classic system? Are you talking about cholera? No, I'm not necessarily talking about cholera, but we can talk about it as well. No, so when it comes to acute gastroenteritis, it's not exactly the same. It's like orange and tomato. We thought that we would have more acute gastroenteritis in those neighborhoods, but it wasn't the case. In a few neighborhoods, there are more than 50% of prevalence. And when it comes to classic surveillance systems, I mean, I put classic between inverted commas because it doesn't really exist at Mayotte at the moment. We could compare that with the results that we got from the nurses at the middle schools, because we know that in the infirmary, we had like a 10% of acute gastroenteritis, but it was at 50% with a surveillance-based, a community-based surveillance system. So we thought that we would have more cases of acute gastroenteritis. And when it comes to cholera, oh yeah, okay. So when it comes to cholera, what we've done in order to adjust the situation to cholera is quite simple. we've decided to extend the surveillance system to adults. We've asked the association not only to focus on kids, but also to try to find new signs of dehydration in children. We've also decided to adjust the reflex information sheet for the healthcare professionals, and we've proposed a training session proposed by International Solidarité, Solidarité Internationale, focusing on cholera, and we didn't notice anything with the community-based surveillance systems. Associations are not necessarily present in every neighborhood, which means that just because we didn't see anything doesn't mean that nothing happens. However, if we notice something, it means that there is cholera in the neighborhood. Hence, at the moment, we have no data on cholera, but it is still quite reassuring. Indeed, if we were to think that there are flare-ups in those neighborhoods, the associations would have detected it. At least we hope so. Thank you very much, Annabelle, for this presentation. And Annabelle will be present with us during the roundtable if you had other questions. It is time now to give the floor to Albin Fontaine. Albin Fontaine comes from Marseille, from the southern part of France, and apparently it is warmer there. And is working for the Biomedical Research Center for the Army, and is also working for the emerging virus department, and is working on the surveillance and the prevention of vectorial diseases. And I will talk about new examples of application in West Nile and Yuzu with a very encouraging results when it comes to the surveillance of vectorial diseases, basing their approach on a few specific vectors. Thank you very much for this very comprehensive presentation. Thank you to all of you, and thank you for inviting me for presenting those results, which are coming from a huge community. So I would like to start by saying that we don't have a conflict of interest with Santé Publique France, and that those researches has been done independently. And it is time now to talk about these situations that you know by heart, the fact that sometimes you have a mosquito just bothering you, pestering you in the night, and if you're living in the northern part of the globe, it must be Culex pipias. Culex pipias is an issue but it's also linked to the USU2 or the West Nile virus, and those viruses are circulating in a cycle using birds as reservoirs and amplifiers and mosquitoes. And sometimes this virus could go above those cycles in order to infect other animals with a spine, such as horses and humans. Most of the time, they have asymptomatic infections, but sometimes we will have a flu-like syndrome, and especially for people who are depressed. You can need meningitis or encephalitis. There are no vaccines in order to protect from this infection in human beings, and there are no specific treatments. The main challenge here, the main risk, is to be infected via a blood donation or the transplant of human organs. So this way you can just infect someone with already which is already vulnerable by giving him an infected blood event because the donor was asymptomatic. So when it comes to detection of the viral genomes, it is a way to prevent ourselves from facing this risk, and it is not done systematically on the entire territory. Its implementation is decided by the High Council for Public Health, depending on the risk involved. Most of the time, it is done after the first confirmed human case. There are a few exceptions. In 2019, in the Alpes-Maritimes region, the spread of the virus was significant the year before, and it is the case as well in 2023 in Charente-Maritime, the Charente-Maritime region. If we were to talk about the emergence of the virus, the West Nile virus started in Europe in the 60s, in the south of France, in the Camargue region. In 1999, we can talk about this new emergence in the United States with the first lineage, creating a new endemic for neurotropic forms, creating thousands of cases and thousands of deaths. And then there was an emergence of a new lineage in 2004. The West Nile virus has encompasses different kinds of viruses. we can count up to 9 different lineages, and 2 of them can infect human beings. The last lineage started up in 2004, leading to a flare-up of the number, an increase of a number of cases. And 2009 was especially in the apex in the number of cases. And in the beginning of the 2010s, there was the arrival of a Usutu virus. On the left, you can see the West Nile virus's data, and it is very localized up to 2022. It is localized in the Mediterranean basin. In 2018, the human cases are in gray, and in 2018, it is over the number of cases of the 10 previous years. What was particular with the West Nile virus and what changed is its epidemiology in France, its emergence on the western part of France in 2022 on the Atlantic coast. And you can see that when it comes to humans, equids, or birds, there were a lot of victims. When it comes to the user virus, I mean, its spread is a little bit more global on the territory, but in 2023, many different cases were detected. The more cases were detected because there was we knew that there were more cases, and we started to detect even more of this virus in blood samples. How is it possible to have an early detection of these viruses before the detection of the first human case? So how could we do that? The first way to detect a virus would be to detect it in with a molecular approach in ill persons. But since we are many different asymptomatic people, it is quite difficult to find who is ill or not. There are a lot of blind spots, and it is the same with animals. There is a serum prevalence system, but it is not a way to propose a specific date for the beginning of the infection. And then I talked about the environmental detection, and there are currently studies going on in order to see what it could do. And then there is the entomological surveillance in order to see if there is an appearance of the virus in mosquitoes. It presents a few advantages. Contrary to other vertebrates, the virus, once infected, will keep the virus during its entire lifespan. There are also a few inconveniences, which is that it is like trying to find a needle in a haystack. It can be quite complex to find the right system, the right virus at the right place. Here we had a study which was provided in the northern part of Italy because they are really infected by the West Nile virus. There is around they will just collect 500,000 mosquitoes, categorize them, created specific pools, and identify who is which mosquito is positive in each pool. It requires a lot of means, and it is quite lengthy. The first ones to find a solution were an Australian team working with Scott Ritchie, and they noticed, for example, in the picture on the top of the slide, as you can see that we are just collecting mosquitoes, we are keeping them alive, we are giving them food, we are providing them shelter, and we are proposing absorbing papers covered in sugar. This way, they will attract a mosquito colony, and they will extract the pathogens present in the saliva of the mosquitoes, which will end up in the absorbing paper. The MX method was born because it is quite difficult and strenuous to find the virus in mosquitoes. However, they discovered that mosquitoes infected by viruses will provide more excrements than saliva. Just to give you an idea, when it comes to the Aegypti, the Aedes, and the dengue virus, a mosquito can excrete between 4 to 5 logs in excrements, but we only have copies in saliva, which means that it is more difficult to detect the virus there. How should we do that? When it comes to MX, we would use the sentinel traps for viruses, and we will replace mesh by a 3D box, providing them food, a shelter, and they will be able to put their excrements in it. They won't be dried up. Wherever they decided to rest, they will be able to put their excrements on an aluminum paper or on an absorbing paper. They will be able to collect the excrements. Here you can see in blue the coloring of the sugar that we give the mosquitoes, and then you can notice that we can get a lot of excrements out of it. And then on the lower picture, we stop using dye, and we see that there are points going from the transparent color and the black color. Black is excrements, and transparent is digested sugar. So there you had a study which was done around the Charnier Lake. We put in place 14 collection spots, and we observed the situation over a fortnight, and we noticed that one fragment could be sequenced, and it ended up being a virus which was very close genetically to another virus which circulated earlier on, which we managed to isolate in a horse. It came from the first lineage, which was an endemic one. Now let's focus again on the New Aquitaine region. As mentioned, we didn't notice an emergence until 2022. We had one USU2 human case and 3 cases of West Nile viruses in horses. At the time, we started to observe a new pattern. The infectiologist, David Balvi, Alexandre Vigneault, thought that it might gain momentum in the next few years. That's why we've decided to put in place a new operational task force in the New Aquitaine region. They've created a link between the detection of the viruses in human beings and in horses. Mr. Béger at the Directorate of the Departmental Directorate for Veterinarian Health, and Camille Minier, which are a part of the reference lab at Maison Alfort, decided to create a mini project research, and Laurent Bijard was there as a facilitator. They've decided to propose a serum-based detection system for viruses, and they noticed that the viruses was spread with horses. That's why at our level we decided to put in place an entomological surveillance system. It has been implemented by the end of July of last year. Here on the map you can see different points showcasing where the traps are. They were located close to swamps in different parts of the estuary, and we were close to stud farms, for example, where we noticed that there were a lot of spread of these viruses, the West Nile virus. And here you can see on the x-axis the time lapse, and then the different circles are representing a detection of the West Nile viruses and the diamond of the OSU2 virus. The color represents the quantity of virus detected. The redder it is, the worse it is. And out of 52 collects, 39 were positive for either or for both viruses or either or. And with detection centers happen everywhere, also in the city center. You can see the genomic coverage that we've managed to get in the sequencing, basic approach, and absorbing paper. The collection happened in the field. The blotting paper was sent via mail from Nouvelle-Aquitaine to Marseille, and then we managed to sequence the virus in less than 10 days. Hence, we managed to be the first ones to showcase that it was the first lineage of the West Nile virus. When we talk about 75% of prevalence, we mentioned that we've selected 7 mosquito collections, and it was a race because this morning we had to grind individually the mosquitoes and to put them in a plate. We needed to use a PCR method, and once we got the results, we needed to check the coordinates corresponding to the mosquito plates, and then it was put in place on a cellular culture, not to isolate the viruses. And many different viruses, West Nile viruses and OSU2 viruses, were isolated that way. We also managed to show the prevalence of the viruses. It can go from 3 to 5%. In some regions, it go up to 20%. And it mentions that the SPPNs is the mosquitoes most involved in this virus spread. We've also detected other species such as Alex rapitus, but just because we're finding a virus in a mosquito doesn't mean that it is a bearer of the virus. The possibility to detect a virus and to sequence the virus is a way to understand where it comes from and to understand how it is distributed and how it is moving. Here you can see the phylogenetic line of West Nile. It can be divided into 3 parts. The yellow and blue parts are the circulating in France and in Italy. Then there are others circulating in Bulgaria and Greece, and the new viruses emerging in New Aquitaine. The New Aquitaine regions are similar to other viruses emerging in Slovakia or Central Europe in 2014. When we are focusing on that, we are in the middle part of the slide, you can see the monophyletic branch, and we don't know what happened to those viruses for 10 years. Did they have like an endemic circulation in Europe and it wasn't identified? Or does it mean that it comes from Africa and that they were introduced in our territory because of migrating birds? When it comes to Usutu virus, it is not the same because it comes from the Africa 3 lineage, and it is not working as clusters in Europe. So our methodology has another perk, which is that when mosquitoes are letting go of excrements, we are letting go of part of their DNA, and hence a part of their pathogens. But also we have samples of the animals they sucked the blood of before they died. Hence, we can provide DNA-based approaches. We can use the DNA of that as a barcode, and it is a way to identify the trophic preferences of the mosquito we collected. We were expecting to see rats, cats, and dogs, but we also found like they are sucking blood of lizards and birds, which could represent potential reservoirs, especially the Milan oak. Here is a slide which is a very simplified system. We have degenerated primers in order to make the difference between vertebrates and invertebrates systems. We can see that the MX methodology is working quite well in order to propose an early detection system and in order to provide the proper surveillance of the spread of a virus in the environment. But what happened in the zoonosis, the virus is starting in the animal realm, but ending up in the human realm. And what happens as well for or urban environments, especially when it comes to chikungunya, dengue virus, the yellow fever, which are all transmitted by the ELS. In 2016, we provided a principal proof, this piece of evidence in French Guiana with the collaboration of the Pasteur Institute with Mrs. Guidez and Monsieur Brionneau. In this case, we knew where they were located, the different Zika cases. We've decided to see what was happening in their gardens, and we've managed to really identify one specific virus. We've used an archaic system. We've collected excrements and saliva, and the excrements of this mosquito were infected as well. It has been done with Sarah Motaillé, who was working on detection in mosquitoes. So it happened once, and it means that we can't generalize anything, but we found the viruses in excrement. So it means that it works. And more recently, during the collaboration with the CEDRE, and the CMEA, which is the Center for Mosquito Control and Entomological Research in the Military Joint Medical Centers, and also the Epidemiological Center for the military. We've tried to identify viruses using these methods in places where the dengue was circulating. So we use the classic methods with a trap used for several days and another new method, sucking mosquitoes. So it means that we are going to different households with the agreement of the inhabitants. We are just collecting mosquitoes there and aspiring the mosquitoes, and once we are waiting for them to let out of excrements, and then we can study the excrements. 3 of them 3 of those mosquitoes were collected during the symptomatic phases of the people, of the members of the households, and others were detected up to a month after the start of the symptomatic phase. Which means that, and we know that there the dengue fever is a recurring issue. The main way to fight against the dengue fever is based on insecticides. However, the mosquito populations are ever more resistant to those insecticides. When it comes to primary dengue fever cases, do you think that collecting mosquitoes which could lead to secondary cases, do you think that it is a crazy idea? I don't know. It is a question. In 2024, the MX methodology will be put at test. We know that in 2023, we didn't really provide an early detection system. It happened nearly at the same time as the human-based SU2 virus case, and it was the same with horses with the West Nile virus. So with operators this year, we are trying to put in place a new surveillance system using limited means because we don't have dedicated funds for that. And until now, since March, we didn't detect any virus, and we see how it evolves in the future. We also benefit from a web app allowing us to share results with the relevant stakeholders, and we also are a part of a broader network of different networks following the same rationale, and they are following the same rationale in the Charente-Maritime, in Nouvelle-Aquitaine, in the Occitanie region, with private labs, with David Simonin, with the IAGE. We also have the Rhône-Alpes region with Vincent Raquin, trying to to provide detections in humid areas, and we also working in the south of France with Nice, Monaco, and Corsica. Let's see if we manage to detect viruses this year. So if you need to keep something in mind, MX is a methodology in order to detect non-viruses in a non-invasive way in the environment. We are just collecting viruses. It is a quick methodology. It is not that costly, especially compared with the classic methodologies. And furthermore, you don't even need to have a specific entomological knowledge. You just need to be able to provide an extraction, and you can go really further. There are no any form of constraints. It is not mosquitoes or excrements. It is mosquitoes and excrements. And let's end up with the final slides. Here are all the different stakeholders allowing us to provide those services and those studies. I won't quote all of them because it would be too long, and thank you for your attention.
Merci beaucoup.
Thank you very much. I have to say that the first time at the outset, I thought, oh, no, it will be difficult to detect anything thanks to vectors. But yeah, apparently we can. And apparently it wasn't that costly because all the mosquitoes were volunteer workers. Yeah, they were. So do you have any questions in the room for Alban? Do you have any questions about what I've been mentioned? But jokes aside, I mean, we are volunteer workers, and we are dealing better with ethical issues because when we are dealing with studies with animals or with human beings, we have to sign specific agreements. And when it comes to mosquitoes, we can do whatever. We can kill them if we feel like it at the moment. I mean. So we might wonder if we could apply this methodology to other kind of vectors. The principal piece of proof has been provided with mosquitoes, especially for malaria, for example. But I don't see why it couldn't work for the flying vectors that could be trapped with those traps, or with lighting traps, which could be adjusted. For example, phlebotomes, cubicoids should work with them. However, when it comes to crowding vectors, could be a little more complex. For example, with ticks, I don't know how it could work, but with the tree atom, it could work. We could just trap them, put them in a container, and provide a community-based detection using different individuals. If screening each of them is an issue on the financial side and on the methodological side. Thank you very much, Alban. We'll try to stay on time. And it is now our pleasure to welcome Laura Espinosa, who is a veterinarian specialized in the One Health approach and specialized in the digital approach. She's working at the ECDC, which is the European Center for Disease Prevention and Control, and she's using AI and new technologies in order to increase the health surveillance systems.
So, sorry. Okay. Then, Suzanne, if you're ready. I'm sorry. Et donc, on a une petite interversion des interventions. Donc, Suzanne Hopkins, qui est conseillère médicale en chef à l'Agence de sécurité sanitaire du Royaume-Uni, tout en poursuivant une activité d'enseignement et en clinique. Elle est par ailleurs membre de plusieurs sociétés savantes, dont l'Académie des sciences.
She is also a member of different medical societies. She will talk about the genomic surveillance of pathogens. It is up to you, Susan. First of all, I would like to thank all the organizers for inviting me. I don't really have a lot of opportunities to speak in French, so that's why I would like to switch to English now.
Of interest. And pathogen genomics, as you've just heard at the last part of the talk on mosquitoes, can really allow us to explore in lots of different ways, different information from human and pathogens and animals and also from mosquitoes. And for many of us, we have been working for quite some time developing pathogen genomics and transferring traditional microbiology into working in pathogen genomics. In the UK, we were one of the first countries to transfer national surveillance for food chain investigations for gastrointestinal infections to pathogen genomics. And we use that now for all of our Salmonella infections that are detected, Listeria, and Shigella toxigenic E. coli. This is really important because it allows us to detect and respond to and narrow down where the food source is. And just now, at the same time as this presentation, we will be doing a large food recall related to Shigella toxigenic E. coli because we are able to highlight that the lettuce that's being produced in a field is related to the human cases that we are seeing. It's also being used to identify reservoirs and link in machinery, such as in cardiothoracic water cooler systems, and link that to human cases many, many years later, where if we just looked at the a classic time, place, person, it would have been very difficult to identify the source of infection. We have used it to control hospital-acquired infections, such as MRSA and C. diff, and carbapenem-resistant bacteria. And we also use it on an ongoing basis to generate information for new vaccines, both new ones that are coming in, but also for seasonal vaccines, in addition to traditional virology and microbiology. In terms of COVID, that really progressed our field of pathogen genomics quite a bit, and I'll come back to that in a moment. So here's just an example for Mycobacterium tuberculosis. From this point of view, when we are able to do genomic surveillance, not only do we then link the data that we get from traditional epidemiology and contact tracing, linking patients, but we also then can use the pathogen genomics to identify potential clusters that don't link from one person to another so easily. And that allows us to identify new potential reservoirs of infection or common sources. And for one large drug cluster in the UK, this identified a particular pub. As you know, British people like pubs, and so lots of people were moving in and out of this pub over time, and actually it was only the detection of lots of disparate people in the community from the same genome that identified a worker in this pub who had been transmitting silently for almost 2 years. it is also really important in Mycobacterium tuberculosis, not just for detecting outbreaks and detecting transmission chains, but also in allowing us to very rapidly detect drug resistance. And so for us, this has shortened the treatment of getting the right treatment to the patient for multi-drug resistance from weeks to days, where we're actually able to give people all of the first line, second line, and third line drugs at the same time, rather than sequentially culturing, which for TB can take many weeks each time. As I mentioned at the start, for gastrointestinal infections, this adds a really extra dimension. Not only does it help us detect infections in country, it also helps us detect infections across countries. And the data that I'm showing here is from a large Kinder egg and Kinder chocolate outbreak that took place just before Easter 2 years ago. And for this outbreak, it was because we were able to share this genomic surveillance data in real time across countries, and then also identify that a food data had a similar genome sequence that was able to link a multi-country outbreak across Europe and identify the source and remove it from the market just before many children would have eaten a lot of chocolate for Easter. In COVID, it was slightly different. So rather than moving it from niche, small areas, it was used globally at huge scale. And what that did was that it transformed how we thought about pathogen genomic sequencing, so that we recognized, first of all, we could do turnaround times from weeks to days. And so in actual fact, the majority of countries were able to turn around time from a result, a positive molecular test result in a lab, to a genome sequence in 48 hours by smoothing processes, by doing high throughput sequencing. And that allowed real-time information to be generated very, very rapidly. At our peak in the UK, we were performing about 10,000 genomes per day. That was about the same as we performed in a month previously for all of our other pathogens put together. So showing that how we could scale the system to go further. Of course, one might argue that that was too much sequencing, but I think it also helped us learn a lot about where we could go next. But it also had real-time impact. First of all, it allowed us to monitor the spread of genomes across the world, and that was only effective because of global real-time data sharing. Secondly, it allowed us to assess and update assays for the detection of COVID-19 by being able to look at the sequence that we were generating and see which of the tests were accurately going to work or not through in silico analysis. And thirdly, over the course of the pandemic, it allowed us to understand how disease was spreading around the world, where interventions had the most impact, and at a patient level, understand the different morbidity, mortality, and vaccine effectiveness for each of these variants as they emerged and traced across the world. And even though now we are performing a fraction of the sequencing that we have done previously, the global genome sharing for COVID-19 has brought us a step forward in how we can do this. So that's a little bit of where we are to now. But I think with our experiences across multiple different pathogens, and particularly with the amplification experience on COVID-19, we believed that the next 5 years shows us that pathogen genomics integration can be possible across a wider range of pathogens and actually be brought much closer to patient care. So we have set out a strategy for the next 5 years. We published this a number of months ago. And the first was to use genomics data to optimize decision-making from local, so particularly at a hospital level or at a clinic level, to global. And that will require us to have a commitment to share the data in real time with global partners. To use this genomic data to drive improvements in diagnostics, in vaccines, and in therapeutics, and to work not just as us in an agency working nationally, but we work with our national health services, our pathology services, and academia to develop high-throughput pathogen genomic services. To be able to do any of this requires a workforce transformation, and so that requires us to think about how people work in laboratories, how people work at the interface with data science and analytics, and then how our public health workforce can understand this and translate the information that they receive into actionable public health outcomes. We believe that in order to do this effectively and grow these services, we are going to have to show how we're developing value for money. It is not good enough, a bit like in COVID-19, to just do millions. We'll have to decide which ones are the right ones, what is the size and scale of surveillance. We've picked 3 priority areas to focus on as a national agency. The first is antimicrobial resistance, to understand how resistance mechanisms spread, both between pathogen, but also from one patient to another, to allow them to control outbreaks, but also to use them to understand how mechanisms of resistance can emerge with new therapeutics coming online very rapidly and very consistently, so that particularly where we have new drugs coming, that we're studying the genome from those individuals who've been treated quite rapidly, so we don't wait until we see clinically significant resistance to understand it better. We're using it for vaccine and elimination programs, and vaccine programs particularly to inform vaccine selection and to look at how we can monitor and evaluate for new vaccine developments, and to support elimination programs through detecting transmission, be that HIV, hepatitis, measles, or other programs where we get to a small number, but then we don't quite understand where those infections have come from and how transmission is occurring. And then probably the most exciting area where I'm involved in is in the emerging infections and biosecurity space. And again, touching on the space that was just mentioned, deploying metagenomic surveillance as an early warning system, because it gives us so much more depth of information than actually waiting till you have a bug or a virus to actually measure. This is already working with partners in our health system to do some of this work in our intensive care units, in individuals with infections for unknown cause, or in those who are returning from overseas, where often clinicians traditionally tested for something they knew, not for something they didn't know. And clearly, from my point of view, if we'd had metagenomics working in ICU in 2020, I think many of us would have been able to detect COVID-19 before we did. Underpinning our strategy will have ethical guidelines. We need to think about the ethics very carefully. Data privacy concerns, particularly when we're linking genomic data from individuals to disease outcomes, but also particularly when we do metagenomics as well from human samples, that we're able to deplete or get rid of the human reads that can sit in those samples. Providing equitable access to pathogen genomic data, ensuring, especially those that are funded by government, that it's a national resource. Because actually what we found during COVID and even before was that actually the more people who look at this and who analyze it, the better pipelines you get, the better data that you get, and the more further we move forward. And clearly in doing this, we need to communicate with the public so that they understand it. So we don't just spring a new test on them that they don't understand. And so it will be a journey to bring them with us. This is just an example of some of the pathogens that we've, and crisis that we've managed in the last number of years. And I'm going to particularly highlight that for both monkeypox and for what we found as an acute hepatitis in young children causing severe disease and death, which was a combination of of 2 viruses coming together in the same time with this particular human genome, that genomics played an essential and critical part for us both identifying these rapidly and then understanding them better. I'm just going to skip that. So I'm going to just focus a little bit on metagenomic surveillance and what I think it's going to help us. So when we look currently about how we understand what's happening in one part of the world, it's through what we call global epidemic intelligence. By and large, that's related to an individual in one part of the world detecting disease. It usually then has to be validated by the national authority. The national authority then has to decide whether it's going to share it and what it's going to share under the international health regulations. It then requires that syndrome to potentially be identifiable. And for many times, this can take quite a long time from a signal being identified that there is a problem to actually understanding what the disease is. If we think back at COVID, even when starting to see the early signals to actually when we first got the genome, that was over 6 weeks. And you can do this in a metagenomic way in less than a week. So in addition, we can look at behavioral indicators such as flu, and we'll probably hear a little bit about that in the next presentation, or syndromic, as was mentioned in the first presentation, where you need individuals to be able to attend GPs or the NHS system to do it. With pathogen genomics, you can design samples from the environment or from clinical samples, so that you can take wastewater and look at what samples are happening in it. You can take mosquitoes, or you can take a patient sample where you've collected it for another reason, but you don't know what the cause is, and design metagenomic surveillance to allow you to understand a greater breadth and depth of what is in there. It really helps bring us along from where the clinician suspects something, and it's only when the clinician suspects something does that go forward. And when I think about that is that, in looking at monkeypox, we were lucky, in my view, that we were able to detect it. The reason is that we had seen mpox from West Africa come into our country recently. We had an unidentified case of mpox in our country that presented very classically, but with no source. Portugal then said they had an unusual rash illness in men who have sex with men. And then we got 2 calls from 2 separate clinics on the same weekend saying, we don't know what's wrong. And so we were putting it through traditional tests, but decided to run it through metagenomics as well, because we wanted to see what is the range of pathogens that could have been there. And that really helped us in being able to identify it rapidly and alert the world. But my true vision is that we get to the point where in complex individual inpatient admissions, particularly in things like ICU, we run routine clinical metagenomics in the way that we now think multiplex PCR is normal, or that we think about culture. In all of those, we are still only able to identify what we know. We never identify the unknowns or the unknown unknowns. So right now, we have got some clinical suspects investigation of the outbreak. We have some designed metagenomic programs with respiratory surveillance in targeted ICUs and wastewater. And we are working towards how we can define the value for money case for a system transformation to transform how medical microbiology and virology is performed in the NHS hospitals. There are some hiccups. I mean, one of the challenges that we've had is that when we're testing an individual from a respiratory sample, we may detect HIV, for example. And how do we talk about that and do that? And we've talked with clinicians and worked with patients, and we have talked through the idea that actually in our hospitals right now, anyone being admitted to hospital in the emergency department should have a HIV test without consent. So it's routine opt-out testing. So actually, if you've got to the ICU, you should already have had a HIV test or have known your HIV status. So this is an additionality on top. We've talked about it for returning travelers. And again, our recommendation are that returning travelers with a fever should have a HIV test. And again, in counseling them about doing this test, which could tell what could be in their blood from a wide range of pathogens, to explain to them that HIV can be detected too. So I don't think the ethics are impossible. We just have to think it through. But my final bit of note of caution is pathogen genomics is just one stream of infectious diseases surveillance. You require epidemiological surveillance, data from the animal environment travel interface, health data from studies, non-health data of relevance, so potentially information about non-communicable diseases. You need information about the society, their mobility, and how they move. And working all of this together really will help and improve health outcomes. And that pathogen genomics is a component of it, but it needs to link it through everything else. And the way we're designing our surveillance systems is that the outputs from pathogen genomics links back to our health record for an individual, both in the healthcare system, but also in our overarching national system as well. New threats will continue to emerge. We are never as prepared as we think we are. And so for me, pathogen genomics is clearly a tool that helps us understand what pathogens are emerging, how they're traveling across the world, and how we can prevent them having the health impact on the population that we've seen over the last 5 years. Thank you.
Thank you, Suzanne. Est-ce qu'il y a des questions dans la salle? On a le temps d'en prendre une ou deux.
Thank you, Susan. Any questions in the room? We'll have time for a couple of questions there.
I did mention that in the elevator, but I want to share it with everyone. Thanks very much for the time UK took during the crisis. You were going through an organizational crisis on top of a COVID-19 crisis. And all throughout the crisis, you took the time to exchange the data, to exchange your views, to exchange the information on vaccine efficiency and things like this. And that was major for us, and I wanted to publicly thank you for that.
Thank you.
And you personally took the time.
Vous avez partagé l'importance.
You've shared the significance of sharing data. Are there reflections on sharing of all these sequencing data, European-wide and internationally, beyond respiratory pathogens?
For our COVID-19 and for flu, that we're quite good at data sharing, but for some other pathogens, it's much less mature. Why we set it out in our strategy and wrote it very clearly was we believe that every genome that we fund as a national institute should go into a public database. And we should do that in real time. There may be very small exceptions to that whilst you are having to understand our process. But my view is that this is a global responsibility, that we share data, not just genomic, but epidemiological too. And the more that we can get out in real time on dashboards, in presentations, but in a way that helps everyone, then the more that we make each of our nations more secure for the health of our population.
So thank you for all this presentation. As we're talking about sharing data, it raises for me a potential problem we can have with equivalence between genomics and phenotypical characteristics, which is sometimes hard for people to grasp and who will take like a genomic value as something absolute. Is it something also that you're planning to address while building up this sharing of data more and more often, including with the general public?
Yeah, well, I do believe that education of not just public health professionals from whatever discipline, but also the public is really important, so that they understand that, like any data, it is imperfect, and that when you start going into genomics and then you go, well, actually, I don't just want the consensus sequence, I want all of the deep sequences underneath so I can understand the variation. You understand the challenges with it. But I think, again, this is like anything we explain to the public. We should explain it to them in ways that they can understand, talk about our level of certainty or surety in what we're doing, and give a level of confidence in the data. I don't believe as scientists we should be talking about absolutes unless we are, there's no doubt, and that's rarely the situation because something will always come and give you something new. But I do think it's really important that we're honest about it because that will bring people on the journey with us.
Okay, thank you, Suzanne.
Thank you.
Thank you, Susan.
Donc là, on accueille vraiment.
Now we're actually welcoming Laura Espinosa. She's still a vet at ECDC, and she's going to be telling us about the new approaches for sanitary watch, and notably with technological resources or technological monitoring.
And leveraging social media data for public health threat detection, and really a bit the road that we went from manual monitoring, prototyping, and escalating an automated monitoring that we developed. I also declare a conflict of interest in relation to the organization or this session. And then just briefly the outline. I'll start with a brief background, especially focusing on what is epidemic intelligence, or as Susan mentioned it there, why social media is relevant for our activities, and as I mentioned, a bit the roadmap of the different activities that we went in really building this project and how we are progressing nowadays. And I will finalize with some lessons learned that could be potentially extended to similar projects like this. First of all, so I'm coming from the European Centre for Disease Prevention and Control, and the aim is to strengthen Europe's defenses against infectious diseases. It's a decentralized agency of the European Commission that was founded in 2005. And epidemic intelligence is one of the core functions of the organization. So it's a process in which we screen different sources of information, some of them unofficial, like media or social media, some of them more official or from restricted platforms, and we also rely on the data that is being submitted from the countries as part of the surveillance processes. As Susan mentioned, we had to really ensure, first in our case, that the data is relevant for our mandate, that is validated, and that we analyze that in order to take action. So just some examples, going back to 2019, the first signal on the, at that time, unknown cases of pneumonia cases in Wuhan was detected by our duty officer on the 31st of December, just before dinner. And of course, considering the time and the day, he immediately started contacting internally. We contacted also our stakeholders, and he managed to get also the official confirmation from the Wuhan website health authorities. And that allowed us to be already prepared, because we published our first threat assessment brief, which is kind of a risk assessment in short, with something that is still a lot of unclarities, on the 7th or 8th of January 2020. So it helps us, say, to try to understand where the other methods or surveillance techniques should chip in when something of this happens. And also in contexts in which the information is not possible to be shared, like conflicts, wars, and so on. Sometimes that information comes from outside on news report that allows the people in the field to really look and go looking for that missing event or a threat that is happening there. So why social media? As it says there, so it's really useful, and several studies shown that social media data, not only for public health surveillance, but also for monitoring real-time outbreaks, and also to understand what is the stance of the public towards these outbreaks. So following this, in 2019, we developed a project which objective was to improve the timeliness and effectiveness of using social media, more specifically Twitter, now called X, for early detection of public health threats. We decided to use this platform, first of all, because we wanted to use what was already developed. There were some R packages that could help in getting the data. The data access level was really interesting because it was free. It was clearly indicating what you could get. So we decided to start with that. And before this project, what we were doing is manually monitoring a predefined list of official and validated accounts, which of course wouldn't be comprehensive because it was impossible to check in our daily feed everything that was happening. And it was also a bit biased because the information that was coming from those sources would be reach us anyway through other sources. So we wanted to be, say, more comprehensive, better quality, but also more timely in the use of these sources. So just a bit, I will explain then one by one in detail. So as mentioned, we started in 2019 with a prototype of what would be an R package. Then in year after, we developed and launched EpiTweet-R, which is the R-based and Shiny app application that allows for detecting public health threats. We developed it for infectious diseases, but actually can be used for any type of topic as long as you have the keywords. And also more than 150 languages, again, as long as you have those keywords in those languages. Then in 2021-22, we started using and implementing EpiTweet-R for our baseline ad hoc threats and mass gathering monitoring. We included in our standard operation procedures. We also developed some training internally and externally, and we share with the different stakeholders that started also including this in their daily screening. Unfortunately, as maybe a lot of you or some of you know, there were some changes last year in terms of the platform and the data access levels, which led us, unfortunately, to stop the use and maintenance of the package from April 2023. But we didn't want to stop there, and actually what we are doing now is we are revising again all the data accessibility to the different social media platforms and possibly reshape a bit the tool and develop give access to new social media platforms depending on the results of this review. So starting with the proof of concept, we started with a non-automatized prototype. The idea was to first start with, as I always say from the beginning, what do we need and what is already out there. So we had a list of some requirements. After doing some market search, we decided to develop a new package ourselves, in this case based in R, as mentioned, for two main reasons. One, that is public programming. We had a capacity in the team to dealing with this coding, and it was getting more and more used in the area of epidemiology and public health. And there was already some packages that allowed to gather the data from the Twitter API. We initially started with two diseases just to test the concept, measles and Ebola, as say July 2019. Then in January 2020, we also included COVID-19. At the beginning, it was more or less useful, but I think it lasted only 1 week after it was so many tweets about it that it was impossible to get something useful out of it. So in this case, what we did was to develop the modules for data collection, aggregation, and visualization, as well as the email notification. That was also one of the reasons that led us to develop our own package, because we didn't want to go to a website and check things. We wanted the tool, in this case, to let us know when something is happening, because with the epidemic intelligence activity, there's so much going on that just having to go there and check, it takes a lot of unnecessary additional time. As mentioned, we didn't include the automation, and we didn't include the signal detection algorithm per se, which we already identify as a key functionality, but it was more to test whether such a tool could be developed instead of putting all the resources and all the efforts and then going to the conclusion that it was not useful. Since we saw that it was actually getting good results, we decided to embark in this adventure of transforming that prototype into an R package and Shiny app. We gathered a team of multidisciplinary experts, going from data scientists, IT infrastructure experts, epidemic intelligence experts, public health experts. So it was a really nice team that led us to develop the first version of this R package. We also had a workshop in June 2020 after a couple of months of developing this first version of the R package, in which we invited potential users of the package, but also experts from the field, especially for the signal detection algorithm, to see which were the options that we could include. Also considering that there were a lot of type of topics being covered and different type of statistical concept, let's say, that we had to consider. When we had the final version after the inputs provided in this expert workshop, we also had 4 beta testers that were public health experts from different institutions worldwide that showed interest in the potential use of the tool, and we also tried with different operating systems, mainly Windows and Linux. We also gave a try with Mac just to see how far these packets could go before going public. And then after all of that, we released the first version in October 2020. You can see there on the top right, more or less, how the Shiny app looked at that time. So the idea was that users could freely download the packets, and then after installing all the requirements and setting up the configuration, the tool will start collecting tweets according to the keywords provided. As mentioned, users could include keywords in different languages. The tool does not automatically translate those, but allows for the tool to collect them. In our case, we focused on 70 topics based on the communicable diseases and some generic topics, and 4 languages, which were English, Portuguese, Spanish, and French. And then, again, it included the signal detection that was not included in the prototype, and also some machine learning models to facilitate the extraction of the geolocation, not only from the users, but from the text. In our case, we are not interested on where people are living when talking about an event or a topic. We are interested actually on the location that is being mentioned there, especially with the globalization that myself, for example, I'm originally from Spain. I'm now working in Sweden, and I may be in a holiday in South America. So it doesn't matter where I've been or what are the places that tie me, but where this possible event is taking place. So as previously mentioned, we had a really rapid increase on the use of EpiTweetR. It was integrated in our daily activities. We had trainings not only for our epidemic intelligence team, but also for the roster that we had on what is called 24/7 duty officers. Each week there's a person that monitors sources throughout the day, and they have also some phone in case of emergencies. And we also presented this in different forums. We also had online trainings with public health experts. And the good thing is that developing this tool as a free open source, our package also enhance its use outside of ECDC. But once you have this tool, we wanted actually to check and evaluate whether it was really what we thought it was doing. So we did an assessment on not only the comparison between the manual monitoring of Twitter with the automated monitoring, but also the modules that we included in these R packets regarding the geolocation and the signal detection algorithm. That allowed us to improve the tool further. We had several versions. So, for example, in the geolocation, we realized that there were recurrent errors from the tool. For example, any time that there was the word real in a tweet, it will allocate it to Ciudad Real, which is a city in Spain, if it couldn't manage to get any other location. So by doing this additional layer that we did on a semi-supervised machine learning approach, then we could manage to improve that from 40% to 60% of accuracy. As you see there, we also developed a community. So initially, we decided to go for a public R script. I mean, everything is still publicly available because we saw that there was a gap. And we thought, if we are developing this, why not make it open source? I'm a big fan of it because you never know if someone else is struggling on the same areas and maybe can get advantage of that. So it had a quite high number of downloads of the package. You see there 16,000. I was checking again this morning. I think these numbers are from last year, around November, or something like that, and it was already 22,000. And we activated what is called in GitHub discussions, which allows also to interact with the online community of this tool. And it was really useful because in one situation, so we would get also a lot of feedback from the users, and in one situation we were about to launch a new version, And just a few days before sending it to the repository of the R packages, a user contacted us and said, look, our IT department has noticed that one of the Java models that you have there has some security issue, and you need to upgrade it to the next one. So by having that information, it took us literally 5 minutes to do it, but then the revision, it takes a lot. So if we would have sent it at the time we were planning, and then we would have had to update everything again, it would have taken us a lot of time. So it was really both-way improvements in that sense. As mentioned, not everything, as we say, that shines is gold, and we faced the situation in which in February 2023, there was some information not clear from the platform, from the company, from X that time already, that they were going to change the data access level. We contacted different stakeholders. We tried to also contact X at that time because we wanted, of course, if there's no data, there's no tool. So unfortunately, we didn't manage to get any reply. I think we still haven't given up. But the situation was that the access level changed, which means that from April 2023, there's a cost attached to it, but it's not even clear. I know the numbers are a bit small, but just to give you an idea, before we were collecting around 10 to 12 million tweets per month for free with the first version of the API. When moving to the second version, we knew that that would be reduced to 2 million, and only 10 million for free were available for academia. But now with this paid version for only 1 million tweets, you need to pay $5,000 US. So as I said, the conditions and information was not completely clear, so we decided to just freeze it for the moment and see what to do. And as mentioned, we are trying to revise. We have actually a couple of days ago finalized the protocol to get information on what is the data that you can access from other social media platforms, in which condition, and which type of data, and hopefully to just revamp what we did with EpiTweeter and make it more modular so then you can get any type of data and the rest of the flow will continue. Just to finalize, lessons learned. First of all, I think this project has shown us a really important thing, which is following the steps of what is called the innovation spiral, from developing a prototype to scaling and finally systemic change is really key to achieve success. Also having a multidisciplinary team, I mean, we've heard throughout the day on One Health, being a vet, I'm quite aware of that, but even going beyond that. So we also need to bring IT experts, IT infrastructure experts, data scientists. We need all of them. And having that type of team behind this development, I think it's really what allows us to have a continuous improvement of the tool and increase the usability. And again, open source tool was also a key aspect, not only to bring to the community what could be a useful tool, but also to get back from the community because you get a lot of more testing that probably you wouldn't be able to do by yourself. One of the things to consider is that, of course, this increased use of the tool also increased the demands for support and further development. So that's one of the things we learned. We were not expecting such a huge acceptance, and we were at some point overflowed with requests, with interest. So for the next time, we will sure consider that in terms of sustainability to ensure that we can reply to all these requests and they can use it as much as we are using it as well. And then again, last but not least, unexpected changes may happen. It's a world that is evolving really fast in terms of technology, in terms of platforms, how the platform is being used. So we need to be ready that we develop something, it may be useful, and at some point not useful anymore, but the process itself is a lesson learned, and we really need to be ready to find what is the next epi whatever R that may make our lives easy in terms of using this type of data sources. Thank you for your attention.
Thank you, Laura. Est-ce qu'on a des questions dans la salle?
Do you have any questions in the room?
As informative, is a tweet needed to have in the text the localization and the etiologic agent, like leishmaniasis and a place in the world, or is just skin scratching and something like this can relate as well to a disease? How do you sorry, screen for the relevance of the first tweets?
Yes, so the idea behind EpiTweeter is that we provided the keywords. We had the list of the communicable diseases in terms of either the disease, and we also had some on syndromic surveillance, especially when coming to mass gathering monitoring, so rashes, fever, vomiting, diarrhea, just to collect those, and then it will show the trend of those conversations. So in terms of the location, we were trying to get the word that was closest to the keywords that we provided for that specific topic. One of the things that this tool is not able to do is to get more than one location. So if there was more than one location, it will get the one that was closest to the initial keyword that we provided. But since we also had this alert, let's say, not only at the country level, but also at the region, or even more globally, if there was something that was involving different countries, then at some point we will see that signal as well in a higher location level.
Thank you very much for your presentation. Patrick Roland from Regions Division. And you talk about the regions. Did you test this approach at different regions level, geographic levels in some countries, test the relevance, the reliability? It could be very interesting to complete the classic surveillance system to help the decision makers.
Yes, thank you indeed. So we evaluated the signals that were collected after deploying the tool, so between October 2020 and December. And in that case, we used the gold standard of the information that we had. So being a European center, we were focusing on those events that we were aware that were relevant for the region, but not that at the country level. I know that some other users have tested it in a more local level, and in other topics, there was one user that was focusing on drug use, and other on non-communicable diseases, and they saw that it was a good addition of the traditional methods. But of course, always on top of, not as a replacement of the other methods.
I have a question. On a One Health perspective, do you have a lot of interaction with the EFSA?
Yes, so in this case, in terms, you mean of the tool or in general? So in this case, for the epidemic intelligence, we are not that close to EFSA because they don't have such activity. In other areas, we have a really close collaboration. So for example, in a previous position at ECC, I was part of the food and waterborne diseases. We would have weekly calls, also in terms of genomic surveillance, developing platforms. We are starting to strengthen in that. We had a couple of months ago, month and a half ago, our network meeting, the annual one, and EFSA was there. We want to, as I say, span and have other agencies to also build this knowledge.
If you don't have any other questions, I would like to thank you, Laura, for your intervention. It is time now to conclude this session and to conclude beautifully those 2 days. Now we have a roundtable with all of our speakers. Thank you for staying for the roundtable. So you can even ask questions as a speaker if you feel like it. So please feel free to ask questions if you're in the room or even online. We will try to take your questions into account as much as possible. We still have a few minutes to go before the end of the session, so let it go. let them go. Let them flow, sorry. So, since some of you talked about a representation, but could you please talk about the different approaches that you've developed? When it comes to those specific approaches, what could be a specific hindrance, or what could be a good opportunity in order to keep on developing this approach in other countries, in a local way or in an international fashion? Who would like to take the floor? Albin, maybe, first. Do you have something to say? Yeah, okay, so thank you. So there are many different obstacles, obviously. When it comes to those different approaches, they are all born from one idea, and then we need to implement them. And when they get implemented, sometimes we have to face a few obstacles. They need to keep evolving. What is quite important here is that there's surveillance. So I don't know if we can say in my case, if we can talk about surveillance, but it should really be connected to research. This surveillance will really nurture this surveillance, but it is a give and take relationship. It goes both ways. And it is the same everywhere when it comes to sequencing or the detection methodologies. Everything is evolving. The viruses are evolving as well. It is like the Red Queen theory. It is the same. When it comes to the technical aspects, when we are located elsewhere in a different context, sometimes we have to face new issues that we didn't even think about, and we need to find new ways to solve those issues. And it is an endless issue, because sometimes we can try to find new ideas and try to find new things which could work or which won't work in specific circumstances. But what is crucial in my case is that we really need to keep being connected to the research environment. Would you like to add something?
When we think about surveillance, it is always going to be slightly different in different countries and different communities. And it always needs to be focused on the public health action that we're going to take. And so in doing that, it's really important that we also bring the users into account. So what is the information that they will need? And are we doing the surveillance in the right way? Are we using the right methods? Can we optimize those methods to make them as cheap and as effective as possible? And so, for example, in terms of pathogen genomics, it's clearly still a very expensive tool. And it is only when we're able to reduce the cost of it will it really be enabled globally. But even still, there are ways that we can work together on it. So, for example, one of the things that we've been doing some work on, and others may have seen some of the work published by one of my colleagues in The Lancet, is relation to the rapid tests that we use for COVID, and actually taking the paper out of those rapid tests and sequencing from those. And that's actually quite effective. And so that could be a tool for low-income countries who are more likely to use rapid tests, and then you can pool those rapid tests together and do metagenomics. So it starts to think differently about how you need to collect samples in different parts of the world with the resources that are there, and how we can share the global resources so that we have truly global surveillance. Another example is that we are working with the CDC to collect wastewater from airlines, and that really allows us to give us a snapshot of who was on that plane and where they might have traveled from and to. And so it doesn't take too many points globally before you start seeing something that, if we all share it effectively, we can understand things better. So I think it's about trying to understand what you want to know, how you want to know it, and recognizing that if we do things in isolation, we won't actually deliver for a global health surveillance function.
Maybe I can add from a different angle. So in our case, we, as mentioned, when we developed this tool, it included a lot of languages. I think it's 157. But then we had a request for a specific language that was not included there. It was really small. And for me, the bottom line there is that maybe that's not the tool and it's not the best way to approach that population. It was taking a lot of time trying to develop the language model to be included in the tool, to get the information that could be available in Twitter, when probably it would have been even faster to just do more community engagement or just collecting the data from other type of sources like radio or other sources. So sometimes we also need to think, and I think I mentioned this example several times, that different forums, that if you want to make a path of 100 meters, we need to check what is the best way of doing it. Maybe a Ferrari is not an option, not because bad of the car or the brand, but because it's so small that then it's better to do another approach. So I think we also need to be open to see, like the different ways of doing it. One of the things we have been doing as well, in areas where they don't have the capacity to look into data, it could be done remotely and then that data being shared. So really trying to use more this globalized approach in which nowadays is not all the support in the field, but can be a bit satellite from there, and ensuring that the different skills and the different knowledge can be used in a better way.
So on my side, it is quite different. We're not really talking about technological innovation. However, we need to stay aware of the cost advantage ratio. When it comes to the community-based surveillance, the financial cost is not that high. However, there is a human cost because the associations should be really involved. And if afterwards the local populations and the associations don't get benefits out of it, it can't work. Hence, we need to understand upstream what we should monitor in order for the associations to do their job properly. So if they should focus on specific symptoms and simple things. But we also need to work with associations which are linked to the problematic. For example, when it comes to the water-based approach, we had to work with associations working on water. When it comes to the supply of free water, it could be quite easy to do. To increase the water infrastructure is only something which can happen on the long term, and the local population and the associations won't be able to see the results right away, which means that they can become disheartened. You need to keep that in mind in order to make sure that the system can evolve properly. Just to go back to the different challenges and the different obstacles that we might face, you've talked about the necessary involvement of the community and of local people. We need to talk about people in the field collecting data, and we know that the sample is sent to the lab. Communication then is key. We need to make sure to involve as many people as possible. And each time we get a result, we need to make sure that it is sent to the local stakeholders. And when there is an issue in the field, we need to talk about it for the other experts to be aware of it. It's not so simple. It takes time. We need to facilitate properly the network. And it is quite a challenge. In order to go further, you need to make sure to contact as many people as possible and to make sure that they're involved. It's not so simple. And at my own level, what I can tell is that when it comes to operators, in order to validate their intervention, they also need to partake in the detection actions and later on in the sequencing actions. They are currently done in a lab, but the technology is evolving quite fast, and currently it's not so hard to sequence something even outside of the lab. It can happen quite quickly, especially when the sample volume is quite low. Which means that in the near future, maybe not everyone, but many people will be able to generate data, to generate new detection, to generate sequencing systems. However, the next challenge will be, how could we validate all of that? How could we make sure that it is the right data? How can we propose a right formalized way to do it in order to validate it? Our system is not really on surveillance because the CNR is doing it with the town-based lab or the hospitals, and then it is sent to the CNR for the CNR to validate the sequencing. At the animal level, the LNR is in charge of it. whatever, when it comes to what is around it, when it comes to the mosquitoes or environmental global approaches, everything is to be done. So we have a question for all of you. How is it possible to manage the right balance between everyone's expectations? Because you said, Albin, that as long as you had data, it was necessary to share this information. Suzanne said the same. And we also need to have the constraint to validate those methodologies. It takes time to develop them, to validate them. And we also need to deal with communities, with decision makers who are quite impatient. They want to get this data and to use this data, even though they have not been validated yet. So how is it possible to manage to reach the right balance, suiting everyone?
So for me, this is a little bit about a community of practice. So one of the things that we've done is we've created a safe space, a safe working space environment in the cloud, which allows academics, our partners in the health system, and our teams to put all of their data in an anonymous way, so that in a real time that everyone is participating. Then everyone puts their tools in that they're using to analyze it, so that people can validate and cross-check each other's tools, so that it brings that sharing of knowledge and sharing of things in a very open manner. It's taken a long time to get there, but and it requires a lot of people. But if you start creating that community, then you are sharing the data with people rapidly who can provide insight and who have tools and who will develop tools rapidly. But then, you know, once you've got an agreed way of analyzing or presenting the data, to create that into a reproducible analytical pipeline to get it to wherever it needs to be as fast as possible. So the problem, I think, is sometimes in traditional epidemiology, we like to get all of our data and take 3 months or 6 months to review it and cross-check it. I think the world has moved on, and so we will accept minor mistakes if for more real-time data. But what you have to say is how you've done that real-time data analysis, because that will make the biggest change possible, and that brings people with you, and they can then help you. I mean, that's one of the great things about OR, is that the community of users on OR improves the tools that are put on there, and everyone can see how everything is done. So for me, you know, having things like GitHub and OR and communities are the ways that we can do things faster and more transparently and show what we're doing in much more real time.
Non, je suis d'accord. Allez, le temps réel apporte une plus-value énorme, mais va.
I think the key here is real time. But if everybody is included in the story, and you know, we might still have to address communication of results or findings. If one communicates without you know, other stakeholders' agreement, then yeah, yes. Well, the SBC, in answer to this question, has been designed and put together to be more efficient, as opposed to having to deal with surveys and reporting surveys and in a specific neighborhood. This is about providing extremely swift feedback to then take action, so that things might not be you know, comprehensive, but at least we're not comprehensive on neighborhoods. It's about for people to respond. We don't step into their dwellings if you know, there's no sampling plan. This is data that might be of a poorer quality, but which drives immediate action.
Not only on the social media as a source that we're using, but as epidemic intelligence in general, we need to deal every day with using less quality data for having a sooner overview. One of the things we have experienced and we had to improve, I think, like all of us during COVID, because the public communication was faster. And then what we managed to find a balance was that we had the two type of sources, and then we are also using that for other diseases, in which one is the data that has been curated, that is being sent by the countries, that at their same time is being sent by their labs, by the hospital, and so on. But then sometimes you will have the reports or media information on, I don't know, events on measles or other type of diseases that you can put there that information, as long as you clarify, you know, this data is less curated, but it can give an earlier signal to understand what is happening. And I think that's an important thing. That, for example, just to show, we are doing monthly reports on measles, and we have the two type of sources. One is the one that is coming from our surveillance system, that is the official data validated and curated by the country, and the other one is the data that has been collected by the experts in our team that are dealing with that topic, and it's being collected from official sources, but also there are some explanations on, look, there's media reporting an outbreak of measles in a specific school in this country. So we put clearly what is the source, we put clearly what is the things you need to consider before validating that information, but at least the information is out there sooner than waiting for that. So I think it's also possible, as mentioned, you know, to not always, let's say, less good data is bad data, because sometimes that's what we need to start, as long as we don't forget also the good data.
Certains d'entre vous, dans les travaux que vous avez présentés, on voit qu'on travaille aussi sur des données qui peuvent être...
And in terms of the reports presented, we can see that these are genomic data, interviews. Have you identified any specific issues with regards to deployment in terms of data protection, in terms of data confidentiality, data sharing? How have you managed to manage these issues in your various projects?
Ça peut être des freins à Mayotte.
Any obstacles in doing so, notably in Mayotte? Well, we don't collect individual data. We collect numbers of diarrheas per household. So we don't do individual data. However, the challenge might be on neighborhoods because the social context in Mayotte is very challenging. We need to pay attention not to identify one neighborhood in particular so as to prevent any movements of citizens that would stop or present obstacles to initiatives. Quite a number of actions have been targeted, quite sometimes violently, by groups of citizens or groups of people. So the challenge is not on an individual basis in terms of data protection, but it is about how can we communicate to the general public without finger pointing some of the neighborhoods. And we haven't come up with a solution, actually.
It's really difficult to communicate small amounts of data rather than large amounts of data. So, and it's much more difficult to start communicating than communicating every day. So I think for me, this is something that we need to change, because I know that when we have a cluster or an outbreak, getting the first report out is always the hardest, because everyone fears the publicity. People don't know how the community is going to react, particularly if you're calling out a particular community or an area. People are worried about stigma, and all of that becomes important. Again, this comes back to my real belief that the more you do it, the more frequently you do it, and the more you sort of normalize the noise, that allows you then to call out when it's important, and that there's a problem here, but actually it was a problem here yesterday, and it's a problem over there the next week. Then people are less concerned, because it's not all focusing on one individual or one population or one community. And so for me, this is again about, you know, improving the literacy in the population about how we use data and why we use data, which I think we did really well in COVID. Not so good at the start, but people got used to seeing this data all of the time, and they expected it, and they wanted to know all the detail about it. And I'm afraid that I think we are now returning to the ways we worked before, where we release data a year later, which is too late, or in an emergency when people are suddenly shocked. There's some happy medium that we need to find.
Maybe I can talk a bit the data privacy for our project. Specifically, it was a tough path, I have to say, because one would think, it's public data. Twitter users already kind of agree on the fact that this data can be public. But then, of course, being a public health institution, we cannot consider that, and we need to be accountable. So that meant that we had to do, to follow the GDPR, also do a data protection impact assessment, and ensuring that everything we were collecting, and again, it was not individual data, but still, if, for example, not to include regions that were too small, because there are some islands that would be considered at the same level geographically as big countries. So we grouped those to ensure that it would be impossible to pinpoint something to a specific individual based on the discussions that were there. And then also we developed new functionalities in the tool that allowed us to take action. So according to the terms of and conditions of Twitter, at least at that time, I don't know if that has changed since last year, any user can ask for their messages to be deleted. So of course, if we have by any chance collected one of those messages, it's already in our repository, so what to do? So we set up a time in which a retention period, after which all individual tweets that were collected should be deleted and only kept the aggregation, so no personal data, and also include this functionality that if someone or some institution would contact us, we could easily either anonymize the tweets in which that user was mentioned or had a post themselves, or just delete them. So I think at the end, now we are more prepared, and that's actually one of the things that we have kind of ready to go in case we want to include other sources, that now we know better what is the process, how to do these things, so we have everything ready in case we want to launch a new version of the tool with new data sources, that this more administrative part that is needed but still slower than what we would want from the epidemic intelligence side is not slowing us.
Et peut-être Albin, tu nous as dit que
maybe Albin, you indicated it was not quite within the scope of your topics related to surveillance because mosquitoes didn't have their say. Well, for ethical consideration, yes, but if we do detect a virus at a given geographical location, well, this might allow to identify a neighborhood. I fully agree with the answers provided thus far. And we need to, if we include everybody from the very start, this will go down much better. And people might be less scared. It all depends on how things are handled, right?
Where you were identifying species that the mosquito has bitten, how did you deal if you found that the mosquito had bitten a human and you had human DNA?
Alors, j'ai de l'ADN humain.
Well, I have human DNA everywhere. And I don't exclude this because it is present everywhere. So with these methods, we can identify whether, we can't identify a given individual. Maybe we could. I don't know. But with my method, I'm just amplifying a region of mitochondria and allowing that's Homo sapiens, but not beyond. But we could find a deeper diversity and identify who has been bitten. There are movies or sci-fi series that incriminated a killer because they found a mosquito that had bitten someone at a given point in time. Is it possible? In theory, it's possible to do that, but we don't go to that extent. We don't go that far. So for the time being, that question is not relevant to us. Thank you very much. You've mentioned quite a number of technical, scientific obstacles about out there on the ground. It's also about ownership. And have you experienced, maybe Annabelle can tell us about this, but have you experienced phases of refusal of projects at the start of these approaches? Refusal related to understanding, and then till at some point the penny drops and everybody understands as to the expectations, the extent, the results that we can communicate. Because at the end of the day, communications can be scary. Have you experienced all of these stages, and how have you experienced those?
Simply, all the time. So when we started to do metagenomics in ICU patients, first of all, we did it completely anonymized. So we would take the sample they did for microbiology, and it would be anonymized, and to show the proof of principle and the point of value. We then started to do work where we would consent patients via their family or via a study protocol, so like doing a research study, so that we could show that actually this is under a research framework that we're doing this piece of work, and it will all be reported through and informed by an ethics committee discussion. And it was only once we had got through those phases where we're then able to show people what we're doing and how we're doing it, and that we can explain to family members how we get the results that we do, that really it's starting to work into clinical practice. So these things are not fast, and at the moment we're going through the exact same process and now doing the study on fever in returning travelers, because we're taking their blood, and people do worry what we might find in their blood. And so again, we're starting with a research framework so people can say no, and that's really important in the first instance. And it's only really when we can demonstrate the value and we're able to show why it's valuable that we would then go into a non-research framework for blood.
En ce qui me concerne, la méthode elle est assez récente et pour l'instant on en est.
Insofar as I'm concerned, I think the method is quite interesting. We are, this is a proof of concept that we're in right now, and things are getting larger and larger. And whenever we come to a new location, we have to explain again and again. It's not that simple. It requires some logistics arrangements. Catching mosquitoes means to set traps. Have to know how to do this. Even if the method is simplified, there's still some things that need communicating. And then this method is neither mine nor that of the lab or that of the institutions. It is open source, and everybody can use this to their own environment for implementation. And indeed, many people come to see us. I think it's nice to develop this together. This is where we are at, and see what happens in the future.
And just to add also for us, I think it was key that we started with a prototype, because in that case it was about 2 diseases that we were following, and we could easily see how things could have been done in a real time, because a lot of the studies that we found, it was retrospective. So what we could have found if we would have done that, but we say, okay, that part we know. What happens if I do it now with what I have it? And it was really important that on the one side to have this small prototype to test, to show, and start showing the results. And actually, when showing those results, we were asked, why don't you do more? Let's do more. Let's start, try to make it bigger. Also, the fact that it's open source. So if someone, like I say, there's any question, you can go, you can check the code, everything is open. You can see how it is. You can change your models. You can change your keywords. So it's adaptable. And I think that also helped in being less reluctant in use in other contexts, or the opposite, that, as I mentioned, we reached a point that it was being or suggested to be overused in situations that maybe was not the best approach. So I think for us, say, prototype and having open source, that then everyone can see what is behind, and it's not just kind of a black box without knowing what is happening.
Non, j'ai pas forcément de choses.
Not much to contribute following what has just been stated. The challenge, in our view, is how to communicate results for this not to be reused and weaponized politically. We don't necessarily have a solution for this, and then we communicate to the main stakeholders that are going to put in place implementation measures, to the regional health authorities, notably, and are well aware of those interests involved. Now, the question now is how to manage to communicate, to make things as public as possible, because we do surveillance to inform the general public without results to be weaponized. One question there. Just one question in terms of the reference to community-based approaches. I think there's some degree of dependencies of associations, given the pressures they're under. They might stop giving feedback because associations can tell you, well, pressures are too high. We need to stop now what we're doing. Any reflections on maybe overcoming or seeing how we can continue receiving data amongst those communities without necessarily resorting to associations, because that's half the population. So we need to know what's happening in these communities. Yes, it could have been an ethical issue if this had worsened situations of associations. That's not the case, because it would come in before we develop these community-based approaches. They would still do this before we require for them to adapt their actions, but we don't ask them to take more actions than what they had done. So associations will continue to go out there on the ground and continue to support these populations, even if we go without community-based approaches. So that's not quite an issue. I don't know if that answers your question. Well, I was talking about improving the quality of surveillance or monitoring. We opted for this type of surveillance because what is out there does not manage to fill the gap and to cover the whole territory, because we have Sursaut and all the other areas. What I mean is, isn't there any other system to improve things? I mean, looking at within these communities, creating community leaders to give feedback on a weekly basis, on the basis of indicators. I don't know. Maybe so we can get data on a continuous basis and permanent basis. I think it would be difficult to put this in place. We've been working on community-based surveillance because this system has been proven elsewhere. We're getting ourselves sometimes to check for efficiency. If we realize it doesn't work, that we're missing information, we'll look into other ways forward. Maybe connected to this question you were talking about how to get acceptance. Could there be people who might feel excluded from this? Maybe you've communicated so well that people might say, well, why is there a selection in a given neighborhood? Why is my neighborhood not included? What about genomic? What about mosquitoes? Same for languages that might not be included in epidemic intelligence. Have you been facing this standpoint? The answer is very simple. Then I would give the floor to my colleagues. I think the population is covered by other surveillance systems. Those who weren't have been added right there. In my view, participative science, citizen-led and community-based science, I don't have much experience in that field, but I think the method is fully compatible with NOT. And it's a right way of getting, information, intelligence for limited cost. It's about people giving a bit of their time with a co-beneficial approach. And because they know what's happening in their neighborhood, and us, the level above, we know what is happening. There's a kind of a bottom-up approach to it. It's extremely difficult because you need communication, you need volunteer. It is a volunteer approach. And this is about, giving traps to primary school children so people can get eggs of a given species and report information to the labs. So that this didn't work out because it was kind of imposed upon the people. And very few came back. And those who came back, were the ones I knew of. So it allows you to see what works, what does not. We simplify the message and really get to them and showing the benefit, showing that it comes from their side, and fostering volunteer approach. And we're working with the brands, delivering the traps. We're going to be working in Marseille during the Olympics and see whether or not we can get people's approval to, set those traps. And there's lots of feedback to be gained and to driving methods improvement.
About being excluded from genomics in particular are lower income, middle income countries, where actually first of all, there's an awful lot of aid goes in, but it goes in for the piece of equipment, and then it sits in the laboratory and doesn't get used. And we're not thinking about the whole system that is needed around it. Do we have the right health system to get samples, or the right environmental system to get samples? Do we have the right people to do the analysis? Not just the putting it into the machine and taking it out, but also the components around it. And do they have ways to communicate to their population about this so that they understand it? So I really worry about genomics being a sort of high-income thing for the next 20 years and really increasing the divide between high-income and low-income countries.
Yeah, in terms of social media, I mean, indeed, that there's a population that is not covered. We knew that, and in our case, we wanted to improve how we were using one platform, because also for the others, we were continuing on manual monitoring. Since we have the mandate focus on the EUEA, we also now, with the new mandate that was recently published, it has expanded a lot. But in that case, we need to have a strong network, because at the end, that's really what works. So with this, the good thing is that it allows us to have some idea on what may happen. It's not a comprehensive idea, but some initial idea in areas that maybe there's no easy communication, or for some reason it's not allowed. So the fact that now, with VPN and other methods that people can connect to platforms from a place, even though that platform is not allowed to use in that context, it still gives an additional information. But as I say, definitely we knew from the beginning that it was not capturing all the population by far, and not even considering only Twitter as such, but it was just to improve that specific source without neglecting the other one. And I say, having a strong network is really important, because for us, as mentioned, I put the example on the Wuhan website. Of course, the language is an issue. We rely on machine translated services, but also we have stakeholders that, you know, if there's any fine information that is not that easily translated, we can contact them. So I think it's important to, I think, as mentioned, not only consider the people in the ground, but also everyone that is working in the area, so then we can really do an effort all together and gain one from the other. So I would say not one system, as many as can cover, because that will increase the possibility of trying to include as much people as possible.
My name is Christine Girardin. I work for the Regional Health Agency, and I would like to go back to what Alban was mentioning. When it comes to the tiger mosquito, there is one specific site where the population can go, and the population is free to take picture there in order to show the kind of mosquitoes that we found there. And then we study the species in order to really determine if we are dealing with tiger mosquitoes, which means that there are existing solutions. Yeah, obviously, there are many different initiatives, citizen-based initiatives going on. At the moment, they are merely linked to the presence and the density of the tiger mosquito on a specific territory, which means that these initiatives are the perfect way to see how the tiger mosquito is moving and where they are located geographically. But we cannot really detect the presence of viruses in the mosquitoes. That's why we are providing a slightly different approach. But you're right, citizen-based initiatives are already ongoing, and we can use phone apps in order to do so. We will like to hear a last question before we conclude this roundtable. The implementation of a new methodology always has a cost, and we tend to limit the resources in the public health environment. So how would it be possible to now sell new methods in this context?
So first, I think you have to try and replace one method with another if it's expensive. Two, if you are going to add it as a new method, you need to be able to explain why this is worth adding. So just getting the same information from a different source is not enough. I like the Mayotte example. You went to places where you didn't have this surveillance. So for us, it's about what we can add. What is its role? It's critical in doing that you consider a lot about what you're going to sample, why you are going to sample, and what you're going to do with the information, because that's what's going to give it effectiveness. But I also recognize that sometimes there are hard choices that you have to make, and that, you know, we can't always proceed as fast as we want to do something new because there isn't enough evidence or there isn't enough money, and we have to prioritize.
Yeah, just to add on that, I think having a clear objective is key, because just going, I mean, now with all the hype on artificial intelligence, you know, I'm hearing a lot. I have this, you know, there's this new large language model that I can use. Where can I use it? Like, no, that's wrong. You know, you need to start with the problem and see whether that's an option, because otherwise we will get some rejection from those that need to facilitate the implementing. And I acknowledge, you know, that they are right. You know, if we just go with a method without explaining what is the problem, what we want to improve, and whether that method could improve it, we will not get anywhere. And also the idea of, you know, it has been mentioned throughout the roundtable now, to have data for action. So not to do things, just to have them there and sitting there. So, for example, with this type of tool, where we say, if you want to use such a tool, you need to check whether you have someone to revise the signals. Because if you are not going to be able to go through that information, not even start, it doesn't make sense. Because then you will get a lot of information that cannot go as it is out and will not be analyzed or filtered or assessed or even validate. But still it takes time and effort to set it up and to collect it. So I think it's important to understand what are the capabilities or what could be done to improve it, have a clear objective, and then ensure that the new methods we are implementing is really to take actions on it.
en ce qui concerne
So when it comes to financing, we can talk about the financing of R&D. Wherever, for example, we need to abide by specific standards. And also, let's imagine that we reach the peak of surveillance methodology. How can we make sure that it is used sustainably on a territory? So should we talk about, if we talk about government funds, I mean, should be a good idea. However, we can benefit from private funds as well. We know that currently there are many different private stakeholders, which can be interesting. Should we talk about veterinarian labs or not? The ideal would be to coordinate their efforts and to make sure that it is profitable economically. I think that one of the major aspects to take into account when it comes to the implementation of these technology methodologies is to think about the assessment of this methodology upstream. Without a good assessment method, we can prove that it is efficient. And if we cannot prove that it is efficient, it would be hard to find fundings. I guess it's time. It's time to conclude this roundtable and to put an end to those fascinating discussions. I would like to bear in mind a few things. First of all, the fact that we need to have a clear goal in order to deploy an idea and to sell an idea of, or should we talk about surveillance or the implementation of a new action. It's not only about generating new knowledge, because if people could really feel like they own this knowledge in order to create specific actions, it would be difficult to provide the sustainability of the action. We also need to be transparent, especially to be transparent about the uncertainty surrounding those innovations. And we should also focus on communications, a transparent communication, in order to involve all stakeholders with us in our endeavors and to be convinced by the added value of those innovative systems which are implemented. So thank you very much for this roundtable. Thank you for your intervention. Thank you for the two organizers of this fascinating session, so Cynthia Tamanjou and Justine Scheffer. And thank you to all of you for participating in this session, both remotely and in person. Let's meet again next year for the Rencontre Santé Publique France 2025. In the meantime, all the sessions are available online. So if you feel kind of frustrated because you didn't manage to follow all the parallel sessions, you will be able to hear what was mentioned online. And thank you very much for your attention.